Good morning. On behalf of the NIMH community, welcome to the 23rd Mental Health Services Research Conference. We're excited to have a record number of registrants this year, to include researchers, clinicians, consumer advocates, government and commercial stakeholders. We have some press here and other esteemed guests. This year, in efforts to extend the public health impact of our conference, for the first time ever, we are webcasting all the plenaries and in select talks as well. 4 months ago, I underwent surgery to donate a portion of my liver to my mother, who was in liver failure and needed a transplant to survive. This story has a happy ending, but it almost didn't. My parents are snowbirds, and for those of you who don't know what that is, these are retirees enjoying that lifestyle who live half the year in Florida and half the year up north. My mom's condition happened to deteriorate while she was in Florida, and that's where she was hospitalized, but her hepatologist was up north. This slide is a picture of the air transport team privately hired to get her from point A, which was a nice community hospital in Florida, to point B, which was where her hepatologist was and the surgical transplant team. It seems pretty straightforward, but unfortunately there's no kayak.com, Orbitz, or Expedia to make this all happen. A much closer hospital in Florida was there, but she didn't have a relationship with that hospital. And to get a relationship, you need to make an appointment, and by the time she would have gone to the appointment, she would have certainly died. So we were left heeding the advice of her hepatologist, who said, get her here. But he didn't know how. Her physicians in Florida didn't know how. Nor, frankly, did we want her physicians being travel agents. So the challenges we experienced really were health services challenges. And some technical challenges. There we go. Okay. So access. We could talk with her physicians via telephone, but there were bureaucratic and physical barriers to preventing the transport. We need to get her from the hospital in Florida on an ambulance to the airport, on a plane to a different ambulance, or to the airport, to a different ambulance, and to the receiving hospital. Now, the receiving hospital didn't want to take her via ambulance. They wanted her to come and walk in so she could have a direct admit. But she was too sick for that. Continuity. So my mom is a wonderful patient, affable, informed, adherent, and assertive when need be. Yet, as her condition worsened, she didn't have the cognitive capacity to be all those things. So family had to step in, or else she would have fallen through the cracks. And we saw this happening. There was no one person at any hospital setting to help with the transitions that we really needed. In each healthcare system where she was a patient, the standard of care was impressively consistent. The downside is that pre-transplant, my mom did not respond to that standard of care. It took a little bit of arm twisting to get her the right care so she could get to the operating table. You know, what a problem it would be for our field if people were following standards too much. Equity. So we were exceptionally fortunate. We had financial resources, academic resources, friends and family who were physicians in and out of the hospital settings. But I have to just make an argument that I think we were probably more fortunate than most. And then value. I think what we got back was priceless. So to lighten the tone a little bit, and speaking of priceless, for some reason this cartoon is not showing, so another technical challenge. I would like to introduce and thank the branch for all their help. Without missing a beat, so speaking of continuity as well, while I was out, they picked up conference planning, and being relatively new to NIMH, they welcomed me very warmly and provided thoughtful guidance and consultation to make sure I wouldn't step in any potholes along the way. So with that, I'd just like to introduce Dr. Susan Azrin, Dr. Denny Pintello, Ms. Denise Giuliano-Bolt, who was here somewhere. There she is in the back. Dr. Agnes Rupp, and Janet Sorrells. There she is over there. So thank you. So in many ways, services research seeks to improve how we identify people and need to get them to and keep them in the best available care. To do that is hard. It's not doom and gloom or insurmountable hard, but hard. We need policy and financial levers within and across healthcare systems. We need to engage leaders, providers, consumers, and their families. And we do this so we can understand the lay of the land, we can develop and test interventions, and then we can eventually implement those interventions. In my mom's condition, going from point A to point B was blocked by institutional barriers. And we were fortunate to put all of our resources into helping her. But helping one person is not public health. Having spent a decade at the Department of Defense, the engineering, planning, and logistical feat necessary to carry out the military's primary mission is nothing short of amazing. Think about what it takes to move people, large weapons, equipment, supplies, etc., across the globe in short notice and at massive scale. After the wars in Iraq and Afghanistan started, the military health system needed to adapt to the growing mental health needs of service members. A series of studies really demonstrated that, yes, it's possible for service members to go from point A to point B, but most did not. As you can see, when we look at the denominator of our target population, we can see that remained consistent. But the numerator, over time, and when you look at each of these handoffs, shrank drastically. Service members were able to raise their hands and say, hey, I have a problem and I want some help, but getting them to any help and getting them to the right help and then looking at the quality of care that they were getting, we saw that decrease. And really what this needed, this message was important because it told us that we needed innovative alternatives to what was considered the gold standard, which was individual face-to-face therapy. And it really catalyzed large-scale systems-level changes across the military health system. And the military health system serves 10 million beneficiaries, to include uniformed service members, their families, and retirees. And those are service members who put in their 20 or 30 years and retired, so different from VA. At 300 military treatment facilities across the globe, in addition to being treated by TRICARE providers as third party, and at a cost of about $60 billion a year. And one of the most influential people to effect these changes, dramatic pause, was the late Dr. Wayne Caton. Though not the implementer of change in the DoD, he really helped shape how the field thought about mental health service delivery. 2 decades ago, Wayne, who many consider the father of collaborative care, identified that patients with depression were not getting adequate care in primary care, and they were falling out of care. He and others, many in this room, dedicated their careers to testing innovative ways to increase access to high-quality mental health care, to ensure that patients got that care and remained in the system. Dr. Caton and colleagues really flipped the way we thought about improvement. So not just the patients sitting in our offices, but those patients in the waiting room and those patients on physician panels who were not raising their hands saying, I need help, but who really did anyway, and we knew this through tracking. He used registries, again, not as a passive repository of information, but really as an active tool to help direct providers where to focus their energies. And then we could measure improvements. So this is treat to target and measurement-based care. And the collaborative care model really helped with all of this. But primary care providers couldn't do it alone. With all that patients bring to that 15 to 20-minute visit, they needed help and a well-integrated care team to include a prescribing mental health consultant and a care manager to do all the things that the primary care provider would want to do but couldn't. And we know through research that a lot of other models have been tested, and the evidence hasn't come in. So, for example, co-location. It's very intuitive to just put a mental health specialist in the primary care clinic, but without that thoughtful integration, we don't see the outcomes that we do otherwise. We know that one major practical implementation barrier to collaborative care was payment. How could providers do this in community settings and get paid at the same time for their work? We're excited that CMS has developed new billing codes for collaborative care. And seems like the bat phone over there. They got new billing codes for collaborative care, and when you click on the website, they're looking for public comment on those billing codes. So feel free to comment. More technical challenges. There we go. So primary care is the de facto mental health service system in this country, and that's a phrase attributed to Darrell Regier from the 1970s. And collaborative care really is about going to where patients are. But other settings can and certainly do provide quality evidence-based mental health care. The RAISE initiative tested whether coordinated specialty care for first episode psychosis would lead to greater symptom and functioning improvement than usual specialty care. It did. And not only that, but RAISE demonstrated that if we can reduce the duration of untreated psychosis, consumers get better more. This landmark study was also deemed to be a high-value treatment, meaning that the improvements in outcomes are worth the investment. Significant health services questions remain, however. We know that the road to coordinated specialty care can be rocky at best or blocked at worst. So we really need innovative ways to smooth out that pathway to increase access to care, and then we know that dropout's also high. So to keep people in care and improve continuity. Our autism portfolio is relatively new for services research. I think many of you know the U.S. Preventive Task Force recommendation that recently came out stating that there's insufficient evidence to warrant universal screening. And in contrast to first episode psychosis, children at risk may not look at risk. Dr. Amy Weatherby at a recent meeting presented 2 vignettes of 2 toddlers, one sitting playing with a toy quietly, really engaged with that toy, and the other playing with a similar toy but kind of distracted, looking around, reaching for the adults in the room. And as anybody who's a parent who has worked with toddlers for a long period of time, man, what a break it would be if that toddler would just sit for a few minutes and be entertained by him or herself. And really, that was the toddler who was at risk. And we know that there's a lot more questions as well. So for example, what screening tools do we use? When to watchfully wait? When to refer to early intervention, which, as I'm learning, is a different setting altogether, often run by the Department of Education. What happens? How long is the waiting time for early intervention? What happens in that black box? What information, if any, gets fed back to the pediatrician, and how is that information then going to be useful? And that's just for children. Children become youths, and youths become adults, and we know very little about that population. The Mental Health Research Network is our prototype for a learning healthcare system. To be somewhat presidential, but not really, we ask not just what research can do to inform the system, but really how can the system inform what research we need to do, and then nimbly implement, test, and refine what's needed. And Dr. Greg Simon, who leads this initiative and who's also a meeting co-chair, will certainly be talking more about this later. So we have a lot of hard work to do to move from point A to point B. And ironically, JFK was talking about going to the moon here with this quote. We're excited and encouraged by all the amazing work done to date, and we're excited and hopeful about the work yet to come. So thank you, and with that, I'll turn it over to our meeting co-chair, Dr. Susan Azrin.
Again, welcome to the 23rd NIMH Conference on Mental Health Services Research. I'm going to tell you what we have in store for you over these 2 days, but first I'd like to say a bit about NIMH's strategic objectives and how they relate to what we're doing here. In 2015, NIMH revised its strategic plan to guide NIMH-funded research over the next 5 years. The NIMH strategic plan has 4 strategic objectives, as you can see here. In our services research and clinical epidemiology branch, we mainly support Strategic Objective 4, strengthen the public health impact of NIMH-supported research. Hence, our conference is grounded in this objective, harnessing science to strengthen the public health impact. We are the critical step that moves research into practice. But these strategic objectives don't necessarily represent knowledge flowing in a single direction, from discovery to service delivery. Service delivery can itself inform discovery, as Mike mentioned. We have 4 specific strategies for strengthening the public health impact of NIMH-supported research. This is killing my momentum. Okay, so these strategies involve improving the efficiency and effectiveness of mental health services, establishing research practice partnerships, developing innovative service delivery models to dramatically improve mental health services outcomes in diverse communities and populations, and evaluating the public health impact. Throughout our conference, you will hear how these strategies are being applied in novel ways. For example, by integrating research and practice to improve the health of entire populations, such as all clients served by community mental health centers who are at risk for cardiovascular disease, or all pediatric patients at risk for autism within a practice. I'm very excited to tell you about the program we've planned for you. You will hear from behavioral health leaders in 2 of our nation's largest cities, Philadelphia and New York City. These are also 2 of our most innovative cities when it comes to addressing their citizens' mental health needs. Commissioner of Philadelphia's Department of Behavioral Health and Intellectual Disability Service, Dr. Arthur Evans, will deliver this morning's keynote address. Dr. Evans led the system-wide transformation of mental health care in Philadelphia, expanding access to care and improving outcomes for the children and adults of Philadelphia. How did he do this? We'll find out shortly. This afternoon, you'll hear about 3 outside-the-box ways that technology is being used to identify people with unmet mental health needs via social media, to engage people in mental health treatment by overcoming barriers to traditional care, and to speed the uptake of evidence-based practices. Mayor Bill de Blasio's administration released the massive mental health initiative Thrive New York City, a mental health roadmap for all, in November of 2015. Spearheading this initiative are the First Lady of New York City, Ms. Shirlane McCray, and Dr. Gary Belkin, Executive Deputy Commissioner of New York City Department of Health and Mental Hygiene. In tomorrow's keynote address, they'll give us their insider's perspective on Thrive New York City. More than 6 dozen scientific papers will be presented in the next 2 days, highlighting our field's most impactful research. Across 5 concurrent session periods, 2 today and 3 tomorrow, you can choose from symposiums, paper panels, and other sessions. And we're webcasting for the first time. All plenaries and 2 concurrent sessions each period will be webcast if you can't make them in person. At lunchtime today, grab your lunch and join one of 5 research roundtables, each facilitated by NIMH program staff. This is your chance to tell NIMH what research you think would have the greatest impact on our nation's public health. Tomorrow morning, our conference co-chairs, Dr. Gregory Simon and Dr. Mary McKay will discuss their vision for the field of mental health services research. Tomorrow at lunchtime, grab a box lunch and come to our poster session. The posters of 24 new investigators will be featured in a special section. These 24 new investigators, the future of our field, were selected through a competitive process and will participate in a full-day workshop at NIMH on Wednesday. I hope you'll agree that if you're passionate about mental health services research, then this is your meeting. If you're interested in how states, cities, and communities are transforming mental health care, then this is your meeting. And if you want to learn about cutting-edge approaches to mental health services research, then this is your meeting. If you want to forge new research and practice collaborations, then you have found your tribe. We began planning this conference quite a while ago and took that photo at our first work group. I think maybe October 1959. There are so many people who worked hard to make our conference a success. I especially want to thank the following. Our wonderful co-chairs, Dr. Mary McKay and Gregory Simon, NIMH leadership for their support of this meeting, our NIMH colleagues in the Services Research and Clinical Epidemiology branch who served as the work group for this meeting, Dr. Lauren Hill and Ms. Denise Giuliano-Bolt for putting together our new investigator workshop on Wednesday, our NIMH colleagues in the Office of Science Policy Planning and Communications, the many abstract reviewers who so graciously agreed to review a record number of abstracts, our creative and tireless logistics contractor, Synergy Enterprises, Inc., especially Terena Yates in the back, Detria Langon, and Ame Natumbe. Finally, thank you all for your commitment to mental health services research and its potential to improve the public health. Thank you. And now it is my privilege to introduce Dr. Shelli Avenevoli, the Acting Deputy Director of the NIMH.
Good morning, all. Thank you very much to Susan and Mike. They thanked a lot of other people, but I want to make sure that they get some thanks, too, for their excellent planning for today's workshop. So I'm very pleased to be here with you today, and I am speaking on behalf of Dr. Bruce Cuthbert, who is currently, but perhaps not for long, the Acting Director of NIMH. And we welcome all of you to Washington, D.C. on this first steamy day of August, a very typical August day in D.C. And thank you for your participation. Your participation both in this meeting and the work you do every day is vital to fulfilling NIMH's mission. Our mission, as you might know, is to transform the understanding and treatment of mental illnesses through the funding of basic and clinical research in order to pave the way for prevention, recovery, and cure of mental illnesses. NIMH supports innovative science across the whole translational continuum, from the most basic discovery science and clinical research, as well as translational research, intervention development, implementation, and service delivery. As mental health service researchers, you play an essential role in leveraging the early points on that continuum to actually impact people's lives and bring a larger impact on the overall public health and the people that we serve. And this is precisely the theme of this year's meeting, harnessing science to strengthen public health impact. As Susan and Michael have given an excellent introduction, we have a very exciting agenda for you, and I look very forward to the dialogue over the next 2 days and to hear about your ideas about further strengthening the impact on public health. But actually, before turning the meeting over to Dr. Heinsohn, I did want to make sure that all of you had heard the news that there has been an announcement as of last Thursday of a new NIMH director, Dr. Joshua Gordon. He comes from Columbia University. We have announcements on our website as well as the NIH website and Columbia University website as well. So there's plenty of information out there. But for those of you who haven't had a chance to read it, Dr. Gordon's research has focused on the analysis of neural activity in mice carrying mutations of relevance to schizophrenia, anxiety disorders, and depression. He has been funded by NIMH as well as several other research organizations. And he also maintains a general psychiatric practice, so he actually cares for patients who suffer from the illnesses he studies in his lab, in his more basic research. Dr. Collins is extremely excited about Dr. Gordon's arrival at NIH, and he has called him a visionary psychiatrist and neuroscientist with deep experience in mental health research and practice. He says he's extremely well qualified to lead NIMH and to improve mental health and treatments for mental illness. We expect that Dr. Gordon will join us in September. The exact date is yet to be determined, but we're thinking somewhere mid-September, and we all look forward to the next chapter. So as researchers, as advocates and friends of the researchers in the field, be sure to reach out to NIMH and let us know your thoughts on where we should go in the future, and I would say there's much more to come. And I'll be around during the break if people have questions, but we don't have a lot more answers about the new director and his arrival than what's already posted on the website. But thank you again, and I'm going to turn the meeting over to Dr. Bob Heinsohn.
Well, good morning and welcome. Welcome to Bethesda, Maryland. It is great to see all of you. There are many old friends in the audience, some going back to graduate school, others that I've worked with over the years in various positions at NIMH, and some whose names I recognize, and I'm looking forward to getting to meet you in person. Excuse me, I just came off annual leave from last week. This is the nicest re-entry into the work world, but I'm still a little fuzzy-headed. But a thing that I wanted to say, this is the 23rd Mental Health Services Research Meeting. And I want to acknowledge that the last meeting, the 22nd meeting, was co-chaired by David Chambers, who is showing his solidarity with mental health services research by returning for the 23rd. David, welcome. Thank you for coming to the meeting. As all of you know, David was a leader in health services research at NIMH for quite a long time. And when he left, we begrudgingly let him go to the National Cancer Institute, where he's continuing his tradition of inspired leadership in that organization. And at that time, we launched a national search for a new person to lead the services research branch. And we were very, very lucky to find, after scouring the nation, just down the road at the Uniformed Services University of the Health Sciences, Dr. Michael Freed, who has, as many of you know, has a very distinguished career as an investigator who's worked on implementing collaborative care in the military treatment system. And he's come to NIMH with a strong background, both as a researcher, as a practicing clinician, and somebody who has on-the-ground experience with transferring knowledge from science into a care system and bringing higher quality service to a greater number of people in need. So we are very, very happy to have him join NIMH, and we're very, very excited about the kind of energy and enthusiasm and perspective that he brought to planning today's meeting. I think I'm going to go to that lunchtime session where we get to meet the new branch chief. I just want to learn more about this guy myself, so I'll be joining you there. Another personnel change, around the same time that Mike came, a member of our intervention research branch, Dr. Joel Sherrill, I was going to say ascended. That sounds a little bit too lofty. Joel volunteered for the position of Deputy Director of DESER, and this has been another tremendous asset to the division. Joel brings a really strong background as in intervention science, a long history of accomplishment at NIMH, and a real enthusiasm for helping to improve the business practices of the division. And showing his worth, Joel is not here right now because he's covering for me at a meeting at the NIH campus. He'll be joining us either later today or tomorrow, and he's looking forward to meeting all of you. So there's been some changes in DESER, and as Dr. Avenevoli mentioned, there's some changes at the top at NIMH. Last Thursday it was announced that Dr. Joshua Gordon will be joining us from Columbia University. I won't add anything to what Shelli said about Dr. Gordon, other than to say that we're really, really enthusiastic about having him come. We're looking forward to working with him and to communicating how on this end of the translational pipeline, the work that's done in the services research world is really critical for moving the ball forward and transforming mental health care in the United States. We've already benefited from the process that preceded the selection of the new director, and that NIMH has been preparing for several months for new leadership. And each division and office was asked to prepare briefing documents that would orient the new director to various areas of science. And that was a really productive exercise for us in the Division of Services and Intervention Research. Gave us a chance to step back, to look at our recent accomplishments, to anticipate where we want to go in the future, and to try to communicate to the new director what are some of the things that we prize about our area of research and how we want to go forward. And one of the recent accomplishments that we looked to was our RAISE initiative, the recovery after initial schizophrenia episode. We've only been doing this 8 years, and I stumble on the name. I'm not going to tell you much about this initiative, but I am going to tell you a few things that we learned about the process of doing high-impact research over the course of the years with RAISE. And I want to show you this by just walking you through this slide. So one of the things about RAISE was we were looking to establish whether it was feasible within the United States to introduce a new standard of care for people experiencing a first episode of psychosis. It was a study that was designed to test the feasibility of a coordinated specialty care intervention that had been shown to be effective in other nations and other healthcare systems, to demonstrate whether it was feasible to train clinicians who work in real-world treatment settings to offer this high-quality care. If it was feasible, to demonstrate that it would achieve results consistent with the prior literature, and to conduct this research in such a way that it was built for scale, meaning that we would have a deployment-focused approach, taking into account the characteristics of community mental health centers within the United States that would eventually deploy this intervention, and that we would have evidence that would show that it could be done, and if you did do it, it would have a good outcome. In designing this initiative, we emphasized partnerships between scientists and key stakeholders, policy stakeholders, clinical administrators, and people receiving care, as a way of assuring that the research would be most relevant to those multiple needs. NIMH identified for itself the goal of engaging with federal stakeholders who have a role in caring for people with schizophrenia at various stages of their illness. The Substance Abuse and Mental Health Service Administration, the Center for Medicare and Medicaid Services, the Social Security Administration, to name a few, to say that we think that this research will be important for you to understand how you might be able to improve your policies towards these individuals. And what happened over time was this was a phenomenally impactful research program that influenced policy to create a new standard of care for people with first episode psychosis. And it started with great science. And some of a representative of that great science is Dr. Lisa Dixon, who's somewhere in the audience. There she is. Lisa Dixon with Howard Goldman and Susan Essick engaged the commissioners of mental health in Maryland and New York to buy on to this idea that it might be possible to implement a high-quality care for people with first episode psychosis, and engage those mental health commissioners as co-investigators in a project, and had them sign on to an agreement that if the research did indeed pan out, that they would go forward and implement these programs broadly. And over time, that program, which demonstrated the feasibility of the approach, by December of 2013 had led those two states to say, yes, we are signing on. We are going to expand this research-based treatment and make it available to people in our states. That accomplishment was very influential to the representatives of our Congress who were paying attention to this area and decided that moving forward with evidence-based care for first episode psychosis was a good thing to do. And they instructed SAMHSA and NIMH to work together to provide guidance to states to illustrate to them how this could be accomplished. And they provided an inducement in the form of an additional $25 million to supplement the Community Mental Health Block Grant Program and set that money aside for establishing these kinds of programs in the United States. That initial investment in 2014 was matched by another $25 million in fiscal year 2015, and in fiscal year 2016, the Congress doubled that set aside to $50 million. And what you can see in the right-hand side of the graph, this combination of relationships between scientists and stakeholders, NIMH forging relationships with key federal agencies, SAMHSA and CMS in particular, has stimulated a great number of states to adopt this new type of program and sign on by creating plans for implementing one or more of these programs in their states by 2017. There's been a 16-fold increase in the number of states that have a statewide commitment to coordinated specialty care compared to the number of states that had this commitment in 2008. So what did we learn from this? We learned that relationships between scientists and policymakers are key to develop relevant information to guide policy and create change. We learned that NIMH has a role, a more active role in this to try to extend that, the reach of the research and to put it in front of federal policymakers who actually can implement change. And we also learned or relearned that paying attention to congressional interests is very, very important. So putting all those lessons together, we were instructing or advising the new director about some of the characteristics or the principles that structure our approach to translational research on the intervention and services end. So we're looking to identify opportunities for near-term traction. In the case of RAISE, it was a population, people with first episode psychosis, and a knowledge base that said we could do better if we were able to deliver care in a feasible way. We would look for populations where there's the possibility of traction, settings where there's the possibility of near-term traction. We learned from RAISE that focusing on real-world deployment issues really speeds the implementation of the research. We cut from the typical or the often cited 17-year delay between the production of knowledge and a change in clinical practice. We went from 17 years to just 7 years in the case of RAISE. So this focusing on real-world deployment issues, key. Fostering partnerships between stakeholders, also key. Looking for those people who are going to make decisions, who need information and make good decisions, and then engaging them in a relationship, a collaborative relationship that makes them part of the research, both so that we can focus the research on the questions of greatest importance, but over time to engage their interest so that there's a degree of accountability once the research is concluded. Finally, we've moved not so much in RAISE, but in other areas to encourage researchers who are working in similar areas to the greatest extent possible to harmonize their methods to facilitate data sharing. And created within NIMH through the National Database of Autism Research as the starting point, a place where data could be collected, offering the possibility for aggregation and mega-analyses. And then finally, arranging our research so that we're setting performance goals to measure progress over time. So these, we tell a story about how each of those principles inform some of the recent priority areas that we've had. Major investments in suicide prevention, where we've set the goal of a 20% reduction in suicide deaths as a consequence of implementing research that addresses that need. Combating early mortality in people with SMI by increasing their access to medical care that would reduce common medical comorbidities that are at the heart of early mortality. Major investment, as was described in autism services research, and moving beyond the early years into studying the needs of individuals across the lifespan. And then finally, additional research on factors related to implementing coordinated specialty care for first episode psychosis. A final thing that I want to talk with you about just for a moment is we've asked ourselves, well, where does the next RAISE-like idea come from? And we could have also asked, where's the next collaborative care-like idea come from? Where's the next opportunity for research that's going to make a major change in the United States? And we did a historical analysis about some of the activities that were precursors to RAISE, and we realized that in both projects, Lisa Dixon's project and also the randomized control trial of John Kane, Nina Schooler, and Delbert Robinson, there were centers that provided infrastructure that allowed the incubation of new ideas, new approaches, and some facile testing of ways of addressing the program. So we rethought our strategy about research centers, and recently we published a new announcement calling for advanced laboratories for accelerating the reach and impact of treatments for youth and adults with mental illness, Alacrity Research Centers. And we see this as a new incubator for innovation in both the intervention and the services space. And what we're looking for here is an approach, a team science approach to complex problems that bring together several different perspectives. First, like RAISE, we're looking for people to identify areas of traction, an area where we're on the cusp of being able to do a better job for a larger number of people and making that argument to us that change is possible. And then bringing into part of that discussion where some areas of innovation where we might be able to use new tools to get greater perspective on the problems. Electronic health records that allow us to collect data in a way that every clinical encounter becomes an opportunity to learn something both about people's disorders, their treatment, and their response. Utilizing new innovations in remote sensing of healthcare information technology, mobile communication, social media, bringing all those things to bear to the conversation. Looking for new insights, areas such as behavioral economics, social marketing, social engineering, cognitive and affective neuroscience that may give us different perspectives on how we may be able to engage people and offer them better care. And then finally emphasizing that part of this conversation needs to include the people who are receiving care, the service users, their family members, and the clinicians who are charged with eventually deploying care. So we think that research teams that include these kinds of partnerships and take this kind of perspective may be very effective in giving us ideas about what the next big initiative is going to be. So in closing, I guess they wanted me to keep talking. So what we're hoping for you for the next 2 days is we really would like this to be an opportunity to exchange ideas. We'd like to know from you what you think are the promising near-term opportunities. Either populations where we've learned enough that there's enough knowledge to say that we could do better if only we implemented the things that we know in a more effective and efficient way, or new opportunities that are associated with changes that surround care systems, that if they were better mobilized, we would be able to do a better job. We'd like your ideas about local, state, federal partnerships that might be very fertile ground for looking for relationships that would dedicate themselves to implementing change once knowledge is developed, and then sharing your ideas about how we can move closer to a continuously learning and improving behavioral health care system. And then finally, I just want to say that your ideas are the lifeblood of NIMH research productivity. Please reach out to us about the ideas that you have for improving access to care, the quality of care, the impact of care for people with mental disorders in the United States. We're happy to talk with you about your ideas, to give you technical assistance about preparing your grant applications, and then offering whatever aid afterwards to make sure that your research gets started in the most efficient way possible and is really targeted for the greatest impact that is possible. We really, it's not a top-down type of approach. It really is a collaborative approach. There are some ideas that we throw out to the field as challenge, but for the most part, we really rely on the creativity, the energy, and the innovation that comes from the scientific community to create the portfolio of research that we want to put forward. So those are my thoughts, and I achieved my goal. I finished within my allotted time. So thank you very much. I'm looking forward to speaking with you over the course of the next 2 days. So have a terrific conference, and I guess we do have a few.
Well, let's give a round of applause. So we'll take a short break now, 15 minutes, and when we come back, we'll hear from Dr. Evans. Thank you.